Welcome to the unholy script. What if a brain scan could reveal not just life, but another life hiding inside it? That was the question no one at Hashan Hospital in Shanghai expected to face on a rainy morning in 2022. A young couple arrived at the pediatric neurology desk, cradling a 1-year-old girl wrapped in a pale blanket. Her head appeared unusually large. Her eyelids moved sluggishly, chasing motion a moment too late. The father explained that she could no longer sit upright. The mother whispered that her daughter now slept almost the entire day. There were no fevers, no seizures, only the strange heaviness of her own head. Inside the examination room, the attending physician measured twice, 49 centimeters, far beyond the average circumference for her age. The reflex tests lagged. The grasp and plantar responses were faint. Pupils reacted to light, but unevenly. Hydrocephalus seemed the likely culprit, excess cerebrospinal fluid, forcing the skull plates apart. Standard protocol demanded imaging before any drainage procedure. Nurse recorded vitals and secured the child gently on the padded table of a 64-slice Siemens CT scanner. The mother stood behind the safety glass, gripping her own wrist as the machine began to hum. On the monitor in the control room, the first axial images appeared: enlarged ventricles, fluid retention, textbook hydrocephalus, then an anomaly, a small region of unexpected density near the left lateral ventricle. The radiologist frowned, adjusted contrast, rescanned. The bright cluster persisted, thin and curved. He zoomed closer, segmented, articulated, like bone. The technicians leaned in. They could see it now, tiny repeating nodes forming, an arc against the parietal wall, vertebral-like. He increased magnification again. The readings matched cortical bone density. Silence swallowed the room. Only the soft click of the cooling fan remained. The scan was repeated under a different algorithm. Artifacts were ruled out. What emerged was unmistakable: a curved spinal outline ending in a cluster of shapes that resembled small limbs. The radiologist printed one frame and slipped it beneath the viewing lamp. "It isn't fluid," he murmured. "It's organized tissue." Another technician, unsettled, suggested a teratoma, a tumor that mimics body parts. The senior doctor shook his head. "Too symmetrical." They called the on-duty neurologist, Dr. Zhong Li. He studied the images in silence, then asked for contrast and perfusion mapping. Under enhanced light, faint vascular threads appeared, connecting the structure to the child's own arteries. Blood flow active and deliberate. Dr. Li traced the glowing outline with one gloved finger. What he saw looked less like a tumor and more like a curled fetus. Spine, limbs, and digits drawn inward toward the optic tract. He ordered an MRI for tissue analysis, his tone calm but no longer neutral. Outside the glass, the parents waited on a hallway bench, watching the shadows of doctors move behind screens. The father kept his hands clasped. The mother's gaze stayed fixed on the floor. When Dr. Li finally emerged, he held an envelope but offered few words. "We need more imaging," he said quietly. "There's a structure inside your child's skull that requires confirmation." He did not call it a mass or a twin or a growth, only a structure. But by the time the next scan was complete, what they would see on that screen would challenge everything medicine thought it knew about where life begins and where it refuses to end. The first scan had left the room in stunned silence. But the second, scheduled only hours later, would leave even the most seasoned surgeons wondering if they were watching biology rewrite itself. By evening, the girl slept under gentle sedation in the imaging suite. Rain drummed against the windows, a slow metronome to the steady rhythm of machines. Technicians adjusted coils, checked heart monitors, and logged the calibration data for the Siemens 3 Tesla MRI. Every movement in the control room felt rehearsed, but no one could shake the feeling that something extraordinary was about to appear on the screen. The machine began its low, rhythmic pulse. On the monitor, thin white lines grew across the dark field, slice by slice, pixel by pixel. The first images showed what the earlier CT had hinted: enlarged ventricles and displaced tissue. Then, on the 15th axial layer, the impossible outline re-emerged, curved, segmented, bone density signatures, exactly where no bone should be. The radiologist leaned forward, sweat collecting at his temples. He refined the contrast and overlaid vascular mapping. Color traces bloomed across the grayscale, one network belonging to the child, another threading into it like ivy on stone. Blood flow from the middle cerebral artery coursed directly into the intruding structure. No artifact, no illusion. Dr. Zhong Li entered quietly, mask pulled down to his chin, eyes fixed on the data. He ordered a perfusion sequence, his voice a low monotone. As the next image assembled, the shape gained depth: vertebral arc, cranial ridge, two thin projections tapering into what could only be limbs. The orientation faced inward, toward the girl's own forebrain, as if drawn to it. No one spoke for a full minute. The hum of the gradient coils filled the silence like distant thunder. Finally, the youngest technician broke it. "It's forming symmetry," he whispered. Dr. Li didn't look away from the screen. "Record everything. Archive under restricted access." He used only clinical words: structure, inclusion, vascular dependence. But the tone behind them trembled. Outside the control room, the child's parents waited beside a vending machine that had long since run out of snacks. Through the viewing glass they could see shadows moving, hands gesturing, screens glowing, but no one emerging. When the door finally opened, Dr. Li carried the printouts as though they might collapse under their own meaning. He spoke softly, measured. "Your daughter is stable," he said. "But there's tissue inside her brain we need to understand further. We'll run genetic tests before deciding the next step." He avoided simpler words: tumor, mass, twin, because none of them were right. Back in the lab, the digital model rendered in 3 dimensions. The curved form rotated slowly on screen. A miniature spinal line, small ribs beginning to sprout, 2 arms bent toward the optic region. Each motionless frame looked eerily deliberate, as though frozen mid-reach. When light from the monitor touched the glass wall, its reflection shimmered over the observers' faces, pale, astonished, unbelieving. Dr. Li signed the preliminary report with deliberate care. Organized embryonic structure, demonstrating sustained blood supply from host circulation. Nature undetermined. Then, under his breath, he added a sentence that never made it into the file. "If this is her twin, it's still alive." Outside, thunder rolled once more across Shanghai. In the radiology lab, the final image kept spinning slowly on the screen. 2 spines, 2 hearts beating in one rhythm. What the doctors would learn next would turn a rare anomaly into one of the strangest mysteries in medical history. When a discovery defies every textbook, the only path forward is careful discussion and cautious disbelief. In the heart of Hashan Hospital, the team gathered to decide whether what they had seen was a medical anomaly or something that challenged everything they knew about life itself. The conference room smelled faintly of antiseptic and printer toner. 6 senior physicians, 2 residents, an ethics advisor, and Dr. Zhong Li took their seats around a polished table. The blinds were drawn, shielding the afternoon sun and muffling the distant sounds of Shanghai streets. On the table lay printouts from the second scan, MRI reconstructions, and perfusion mappings. Each image showed the same impossible outline: a small articulated spinal structure, tiny limbs, delicately aligned along the left cranial cavity. Dr. Li opened the session. "The patient is stable. The tissue we've observed is dependent on her circulatory system. No autonomous function is evident. I've labeled it as an organized inclusion for now." One surgeon leaned forward, frowning. "You're saying it's alive, but not alive?" "Correct," Dr. Li replied. It is sustained by her blood flow, but it is not a separate organism in the traditional sense. A younger resident hesitated. Could it be a highly differentiated teratoma? Dr. Lee shook his head. Too symmetrical. Too articulated. This is not a tumor, it's structured as though it were meant to grow in a coordinated way. Like an embryo, but incomplete. The ethics advisor, a quiet woman with sharp eyes, spoke next. Even if we classify it medically, we must discuss the implications. Any intervention carries risk to the child. If we cut blood flow abruptly, the host could be harmed. But if we wait, it may continue expanding. Another surgeon chimed in, his voice tense. So we're talking about two dependent lives in one body. We need a staged approach. Gradual reduction, continuous monitoring, surgical resection only when safe. Dr. Lee nodded, clicking through the 3D reconstructions on the projector. The spine rotated slowly, arms slightly bent, reaching inward as if toward the child's own optic nerve. No one spoke. Only the low hum of the projector filled the room. Have we ever seen anything like this? One resident asked quietly. Dr. Lee leaned back, tracing a finger along the projected image. There are fewer than 20 documented cases worldwide. Most were dismissed as anomalies or teratomas. Some were removed surgically. Many did not survive. But in each case, the surviving host exhibited enlarged cranium and impaired coordination before discovery. This pattern persists across centuries. The ethics advisor exhaled slowly, so we proceed cautiously. Every step documented, every observation archived. The public sees only neutral terminology. No images, no sensational words. Dr. Lee nodded again, eyes fixed on the glowing outline. We maintain anonymity. Record vascular dependence, monitor EGs, track perfusion. Nothing more until we can understand the mechanism. Nothing speculative. Outside the conference room, the city's rain softened into a drizzle. Inside, the team debated quietly, each weighing science, ethics, and the unspoken awe that settled over them. The small figure on the scan seemed almost deliberate, its limbs poised as if frozen mid-dash motion. By the time the discussion ended, the anomaly had transformed from a medical curiosity into a living mystery. Everyone in that room understood the same unspoken truth. Whatever was inside that girl's brain, it was more than tissue. And the next step could change everything they thought they knew about life itself. The scans had confirmed the impossible. Now the team faced a question no medical textbook could answer. How do you operate on a child without harming what seemed almost alive inside her? The surgical suite smelled of antiseptic and polished metal. Monitors blinked steadily, heart rate tracing smooth curves across glowing screens. Dr. Zhong Li gathered his team of 4 neurosurgeons, 2 anesthetists, and a technician. Each member understood the gravity. This was not just surgery. It was a high-stakes exploration into an unknown world hidden inside the child's own head. We proceed cautiously. Dr. Li began. Our goal is to isolate the vascular flow feeding the inclusion, then remove it gradually. No sudden interruptions. Every step monitored. One anesthetist glanced up at the monitors. Her vitals are stable. But any misstep, even a slight drop in perfusion, could compromise her cortex. Agreed, Dr. Lee said. That's why we've rehearsed this procedure in the simulation suite. Every incision, every retraction must be precise. She is not a typical patient, and this is not a typical structure. The room fell silent, the only sound the soft hiss of oxygen flowing into the child's mask. She lay under sedation, tiny fingers curled against the sterile blue sheets. The rain outside tapped softly against the glass ceiling of the hospital, echoing the rhythmic hum of the surgical lights above. Dr. Lee gestured to 3D. Vascular model projected in the corner. The middle cerebral artery feeds the inclusion directly. Gradual embolization, step by step. Monitor EEG. Monitor perfusion. Every beat of her heart is critical. Understand? One wrong move and the risk to the host is immediate. A resident whispered, almost to himself, "It looks like it's reaching for her eyes." Dr. Lee didn't respond. He knew the image had unnerved even the most seasoned surgeons. The tiny, articulated limbs of the inclusion extended toward the child's optic tract, frozen mid-motion. In the digital model, it seemed deliberate, precise, almost conscious of its place. "We document everything," Dr. Lee continued. "No interpretations in the chart. Neutral language only. Organized tissue, vascular dependence, perfusion readings. Nothing more. The world isn't ready for speculation." As the surgical team prepared scalpels and suction devices, monitors beeped in soft unison. Lines of perfusion traced across screens, the child's pulse synchronized with the tiny, dependent flow into the structure. The rhythm was mesmerizing. Two systems, intertwined, neither fully independent. "We have one shot at this," Dr. Lee said quietly, almost to himself. "Every millimeter matters. Every drop of blood counts. And if we do this correctly, she can survive whole, intact, and free of the structure that has grown inside her unseen for months." Outside, the parents waited, unaware of the technical precision unfolding behind the glass. The father gripped his hands, knuckles white. The mother pressed a sleeve to her eyes, hoping the sedation would keep her daughter safe. "Let's begin," Dr. Lee said, nodding to the team. "And remember, every movement tells a story. This isn't just surgery. It's history in motion." As the first incision traced the curve of the skull, the monitors lit up with dual rhythms, pulsing like a secret heartbeat. No one knew what they would find once the membrane was exposed. But one thing was certain. By the end of this day, the impossible would either be undone or revealed in full. When the skull was opened, what lay beneath wasn't simply tissue or anomaly, it was a hidden world. Carefully organized, silently alive, and utterly inexplicable. The cranial plate was lifted with steady hands. A faint crack echoed across the silent suite, followed by the soft hiss of suction clearing irrigation fluid. Light from the surgical lamps spilled over the dura, now slightly bulging under the pressure of the structure inside. Dr. Lee leaned in. Eyes narrowed, tracing the contours visible through the thin, translucent membrane. "Slow and steady," he murmured. "Document everything, one step at a time." The team moved with synchronized precision. Each instrument, each gesture was deliberate. Underneath the membrane, subtle ridges and curves suggested something more than random tissue growth. A tiny vertebral line traced along the cavity, faint but unmistakable. Two small projections, arms extended toward the child's optic tract, half bent, frozen in an almost purposeful pose. One resident swallowed hard. "It's almost like it knows where to reach." Dr. Lee did not answer. He focused on the perfusion monitors. Flow is stable. Dual rhythms are intact. Every millisecond counts. If we misstep, the host cortex is at risk. The structure's vessels were delicate, threading through the child's own arteries. The team employed microsuction and fine cauterization, carefully isolating the feeding artery. Each motion was measured, rehearsed, precise. Outside the cranial window, subtle shifts in color reflected perfusion changes, visible in real time on the monitors. "Watch the pulse," Dr. Lee instructed. "It's not autonomous, but it moves with her heartbeat. Any sudden drop, and we stop immediately." The atmosphere was tense. Machines hummed, screens glowed, and the soft metallic scent of the operating field lingered in the air. The child's chest rose and fell in even rhythm, perfectly aligned with the faint flow feeding the structure inside. For a moment, the team simply observed, aware that what they were witnessing defied expectation. "She's stable," whispered one anesthetist. "But the form, It's precise, symmetrical. How can this exist inside her? Dr. Lee traced the tiny skeletal outline again, noting each vertebral segment, each faint rib, and the tiny limb structures. This is history recorded in real time, he said. Every move, every flow, every vessel tells a story. And we are its witnesses. Slowly, the team began the delicate process of separating the structure from the surrounding tissue, micromillimeter by micromillimeter. The flow decreased incrementally, carefully mapped on monitors. Each adjustment triggered subtle color changes on the screen's red, blue, green, tracing oxygenation and perfusion with mathematical precision. Time stretched. Outside, the hospital corridors were empty, lights dimmed, rain whispering against the roof. Inside, every eye was fixed on the tiny world within the girl's cranial cavity. The structure's frozen posture seemed almost deliberate, as though aware of the hands that moved around it, the pulse that carried life through it. And then, just as the team paused to reassess the delicate progress, the monitors flickered an unexpected spike in the flow, subtle but unmistakable. What could trigger such a pulse in tissue that had no independent heart? In that moment, the boundary between anomaly and mystery blurred, leaving everyone in the room holding their breath, wondering what would happen next. Just when the team thought they understood the anomaly, the monitors told a different story, a pulse, subtle yet unmistakable, beating inside tissue that should have been inert. The surgical lights cast long shadows over the sterile field. Dr. Lee leaned closer, eyes scanning the screens with surgical precision. The child's heart rate remained steady at 118 beats per minute. Yet the dual perfusion graph flickered a faint echo, a secondary rhythm rising and falling in near-perfect alignment with the child's pulse. "It shouldn't be possible," muttered one resident. "There's no independent circulation, no heartbeat." And yet, there it is. Dr. Lee didn't respond immediately. His gloved hand hovered over the touchscreen, adjusting magnification on the 3D vascular model. The tiny structure within the cranial cavity seemed to shimmer under the scan overlay, its arms slightly curved, reaching toward the optic tract as if trying to sense the world outside. "We maintain perfusion," Dr. Lee said finally, voice steady but tight. "Any sudden cutoff could compromise the host. But we document every change. This reflexive flow must be captured." The team held their breath. A perfusion spike appeared again, just as faint as before, almost rhythmic, almost deliberate. The anesthetist adjusted ventilation, double-checked leads, confirmed there were no artifacts. Everything was functioning as it should. The pulse persisted. "This is extraordinary," whispered the technician. "We're seeing tissue respond as if aware of its environment." Dr. Lee's eyes narrowed. "Not aware. Reactive, dependent. But the precision of alignment. It's consistent with embryonic formation. Yet it has no independent heart, no sensory input. How it maintains this flow is beyond current understanding." The surgical team continued the delicate dissection. Microcautery and suction were employed with painstaking care. Every millimeter was documented, every change in perfusion recorded. The dual rhythm persisted, neither fading nor accelerating, perfectly synchronized. A mechanical duet of life and support. Outside the suite, the rain had intensified. The patter against the windows mirrored the pulse on the screens, soft, steady, relentless. Within, Dr. Lee consulted with his colleagues quietly. "We proceed incrementally," he said. "Partial occlusion first, monitor EEG, track every millisecond. Only when stability is certain do we attempt full separation." A young resident glanced at the monitors again. "It's almost like it's breathing with her." Dr. Lee didn't answer, but his finger traced the tiny vertebral line, the faint limbs, the curvature within the cranial cavity. "Every flow, every microcapillary is accounted for," he said. "If we rush, the consequences are irreversible." Hours passed in tense silence, punctuated only by the hum of machinery and occasional whispered updates. The dual rhythm continued, a quiet reminder that what they were dealing with was neither fully passive nor fully alive, existing in a delicate balance between the two. And then, just as the team prepared to advance the separation, the monitors displayed a subtle surge spike in the secondary pulse, brief, precise, almost intelligent. No one moved. Every eye was fixed. What could trigger such a coordinated pulse? In that frozen moment, the mystery deepened, leaving the team on the edge of discovery and fear. Every heartbeat was a countdown. Every microcapillary traced across the monitors felt like a whisper from the unknown. Could they finally separate the structure without harming the child, or would a single misstep undo months of meticulous care? Dr. Lee took a deep breath, surveying the surgical field. The child lay under sedation, the cranial cavity exposed, monitors glowing with dual rhythms. The tiny vertebral line and delicate limbs remained frozen, yet perfusion flowed in perfect synchrony with the host's heartbeat. Incremental, Dr. Lee reminded the team. Partial occlusion first. Observe EEG, observe perfusion. Only advance if absolutely stable. A microcautery tool hovered over the first connecting vessel. The resident's hand trembled slightly, betraying the tension. "Do you want me to proceed, Dr. Lee?" "Yes," he said, voice steady, but with an edge of gravity. "But remember, we're not cutting just tissue. We're guiding a delicate balance between two lives dependent on the same circulation." The first vessel was isolated. Slowly, ever so slowly, the team applied microclamps, observing the monitors for any fluctuation. The dual rhythm held. A collective exhale passed through the suite. "Good. Proceed to the next," Dr. Lee said, adjusting the magnification on the 3D model. "Every millimeter counts. No assumptions. No shortcuts." As the next vessel was isolated, a subtle shift appeared in the secondary rhythm. It surged, faint but perceptible, like a hesitant acknowledgement of the disruption. The anesthetist noted the host's vitals, confirming stability. "She's holding," he whispered. For hours, the team worked with painstaking precision. Suction cleared irrigation, micro-instruments traced tiny vessels, and Dr. Lee's eyes never left the dual monitors. Each separated connection brought the structure closer to independence, though the secondary rhythm remained tied to the host, a fragile tether, neither alive nor inert. "Almost there," Dr. Lee murmured. "Just a few more vessels, and we can begin full resection. Watch the perfusion. Any spike or dip, and we stop immediately." The room seemed suspended in time. Even the rhythmic tapping of rain against the glass ceiling had faded into a hushed silence. Every team member was acutely aware that a single miscalculation could compromise everything. At last, the final microvessel was identified. Dr. Lee's gloved fingers trembled, just slightly as he guided the clamp into position. "Prepare for final separation," he instructed. "Steady hands. Watch every monitor. Every microsecond is critical." The clamp closed. Perfusion slowed gradually. Monitors held steady. The secondary pulse began to fade, tapering off in perfect alignment with the host's heartbeat. The structure, no longer dependent on shared vessels, remained intact but inert. "It's done," Dr. Lee said softly, almost in disbelief. "No independent heartbeat, no autonomous flow. But the separation is complete, and the host is stable." The team allowed themselves a quiet moment of relief. The child's vitals remained strong. The monitors showed normal rhythm. Months of careful observation, planning, and precision had culminated in a successful outcome. Yet as Dr. Lee observed the separated structure, lying under sterile light, he noticed a faint curvature, a subtle alignment that mirrored the child's own optic tract. Could it truly be inert, or was there more hidden inside that no monitor, no scan, could yet reveal? The mystery was not over. And for the team, the questions were only beginning. After months of mystery and tension, the question lingered. Could life truly resume as normal, or would the invisible echo of the anomaly continue to shape the child's existence? The child rested in the observation unit, still sedated but stable. Monitors displayed steady vitals, heart rate, oxygenation, cerebral perfusion, all within normal range. Dr. Lee and the surgical team gathered quietly, reviewing scans and perfusion maps. "She's stable," whispered one resident, awe in his voice. "But look at these microcalcifications. They trace the same curvature as the structure we removed." Dr. Lee nodded. Double quotes, "Yes. Post-operative deposits. Likely residual skeletal traces of the separated tissue. They hold no active circulation, but they tell a story. A silent echo of what was inside her." The mother sat nearby, notebook in hand, documenting each subtle movement and change. "She sometimes reacts to light differently," she said softly, turning her head abruptly, almost as if she senses something no one else can see. Dr. Lee did not comment. He understood. These small, inexplicable behaviors might reflect neural adaptation, residual reflexes, but in truth, they were the final mysteries of the anomaly. Days passed. Rehabilitation sessions began. Physiotherapists guided the child through assisted standing, simple movements, and gentle exercises. Each step was painstaking, yet the child responded with surprising resilience. Her balance improved gradually. Speech emerged in small fragments. And through it all, monitors recorded no recurrence of dual perfusion. "The anomaly is gone," Dr. Lee explained during a consultation with the parents. "The structure no longer draws blood. You will see gradual improvement. But we will continue to observe, document, and learn." Meanwhile, Dr. Lee continued his personal review. He examined the 3D scans, perfusion data, and EEG recordings. The faint curvature of residual deposits, the alignment of microcalcifications, and the subtle reflexive responses all suggested one truth: nature had maintained a pattern, even when separated from life. "It is a reminder," he murmured to himself, "that life can persist in forms we cannot fully comprehend, and that the boundaries between anomaly and normalcy are fragile." At night, the hospital corridors were quiet. Dr. Lee stayed behind, reviewing the final encrypted CT sequences. Frame by frame, he traced the tiny limbs, the faint vertebral lines, and the subtle orientation of the structure toward the optic tract. Even in separation, the echo of its presence lingered, a silent testament to the anomaly that had existed within. Months later, the child returned for follow-up scans. Residual deposits remained, static and harmless, yet striking in their precision. She stood with assistance, eyes bright, movements deliberate. And somewhere in the delicate balance of her recovery, one question remained: what other mysteries of life could exist silently, hidden, waiting to be discovered by those who dare to look closer? Months had passed since the delicate separation, yet the child's story was far from over. Every scan, every tiny movement whispered that the mystery had left a lasting impression. The hospital corridors were quiet in the early morning. Dr. Lee entered the observation room, reviewing the latest MRI slices. The child, now more alert, sat supported by her mother. She followed the sunlight filtering through the blinds with steady eyes. "She's stronger today," the physiotherapist noted. "Balance is improving, reflexes are more responsive. Even speech is forming." Dr. Lee examined the images. Residual microcalcifications remained, tracing arcs where the tiny vertebral lines had once aligned. "Harmless," he said. "Yet they are a permanent imprint of a life that existed within her, even if only dependent on her own circulation." The mother gently took notes in her rehabilitation log, writing every reaction, every glance, every tiny twitch. Sometimes she turns toward the light suddenly, As if sensing someone, she said. Dr. Lee nodded. It's likely neural adaptation, but it's also a reminder of what was once there. At the bedside, junior residents whispered among themselves. Do you think she remember it? One asked. No, Dr. Lee replied, but her body will carry the evidence. Life leaves traces where we least expect. The team allowed themselves a quiet moment, reflecting on the months of preparation, observation, and surgical precision. We witnessed resilience beyond expectation, Dr. Lee said softly. And in the process, we learned patience, care, and the delicate dance that sustains life. And yet, as the child's eyes followed a flickering shadow, everyone in the room felt it. The anomaly may be gone, but its echo remained silent, precise, and waiting to reveal more secrets in the subtle rhythm of life. Even after the anomaly was removed and recovery appeared complete, one question lingered. What secrets still lay hidden, unseen, in the quiet corridors of the brain? 6 months later, the child returned for routine follow-up. Dr. Lee reviewed high-resolution MRI scans. Every previous microcalcification remained in place, unchanged, stable. Yet a faint, almost imperceptible shadow appeared along the occipital edge, a subtle, curving outline reminiscent of the tiny hand removed months before. It shouldn't be there, whispered a technician. No blood flow, no tissue activity, nothing. And yet, Dr. Lee adjusted the contrast, zoomed, and examined the shadow. It mirrored the position of the previously removed limb, perfectly aligned with the visual cortex. A silent memory of the structure, he murmured. No threat, no life, but evidence of an imprint we cannot fully explain. The child, unaware of the discovery, played quietly in the corner. Her movements were normal, her laughter clear. Yet the monitors, once witnesses to dual rhythms, now reflected only her own heartbeat. The room felt suspended in quiet wonder. Life can leave traces where we least expect, Dr. Lee said. Even when intervention is complete, even when survival is secured, there are mysteries that remain beyond our reach. He archived the scans, anonymized the records, and prepared the documentation for internal review. The anomaly was classified as non-viable tissue, fully separated, yet the subtle imprint remained. It was a reminder that even when science succeeds, life retains secrets that evade full understanding. As Dr. Lee powered down his workstation, the faint curve on the MRI seemed to almost shimmer in the screen's glow. And in that quiet moment, he realized the story was over for now, but some mysteries, no matter how small, never truly end.